I do have a background in mental health, so I think that kind of would be helpful for you to get to know more about mental health in itself, because it is a specialty area, right? And everyone sees mental health at one point or another on MedSurg, right? In one form or another. But it's very different to work with strictly behavioral health patients, okay? So that's why I'm here today, and I'll be with you for 3 weeks. So I'm not going to lie, mental health is tough, because I'm sure you remember from pharm, the meds are tough, okay? I won't sugarcoat that. It is difficult to get to know these meds and things like that. And some of the way the brain works, right? It can be difficult. But I think it'll be a nice break from what you were doing. So just come in with an open mind, you know. I think you'll really enjoy parts of it at least, because like I said, you're gonna see this at some point in time in your career, no matter where you are, okay? So my name's Jordan Liggett. I started out on 2 West Oncology Hospice. So a lot of mental health there, right? Caring for patients and their families through a very tough time. So I started there, and I've always loved OB and peds, so I actually went to OB from there. And I worked at Avita Gallion for a couple of years, and I really loved that, but I went back to school for my master's, and I needed a different schedule. So then I was like, hey, behavioral health has some openings. So I went there, and I actually really loved it. So I really liked everywhere I've been. It offered me a different way to round myself as a nurse, right? Because we have to have a lot of different features to make ourselves a good functioning nurse, okay? So we're gonna get started with some mood and cognitive disorders. This is kind of just your introductory. We're gonna talk a lot about depression, bipolar disorders, and things like that, okay? The first page, maybe not. These are a lot of objectives, right? Similar to Mrs. P, I like to have you look at the study guide, look at my objectives that I have for you, okay? This is just the objectives listed on a slide. But again, please look at your study guide, because that's where I'm gonna pull things from, okay? First one we're gonna talk about is mood disorders. So that's classified by your major depressive and your bipolar disorder, okay? You may also hear to these referred as affective disorders, okay? By affective, okay, I don't mean that you're an effective person, okay? I mean, this is your emotions, okay? How do we feel every day? Okay, you're gonna see probably one of 2 things: a depressive state, or that down in the dumps feeling, or a manic state. Has anyone seen anyone who's been manic before, like a true manic state? Okay. I don't just mean you're very excited, you're very uppity, okay? I mean, these people can literally not sleep for days at a time, okay? I worked night shift for the majority of my behavioral health career, and let me tell you, 4 o'clock in the morning was their favorite time. And I was like, I'm not there with you right now, I'm very tired, but they're always up here. The energy never stops, okay? I want snacks, I wanna walk the halls, I wanna pace, I wanna do this. It does not stop for days on end. As you can imagine, that can actually be very dangerous, okay? We need sleep to function. We need food and water to function, and these people are so elevated, they cannot do either of those things, okay? So as a nurse, it's very important for you to say, hey, you haven't been eating, you need a snack. Okay, give them something handheld so they can walk the unit with their snack. Okay, we have to constantly reassure or reinforce that they need to be eating and drinking. Okay, so you can see that with any of these 2 mood disorders, major depressive, you can still have manic states. Okay, and bipolar especially, and we're going to talk about that more. Okay.
Jordan, I know Anna highlights parts of her things through it. She wants us to have to examine yours as well.
I'll have highlighted information, yes. But this is like your overview. If you don't know the differences here, you're not going to be able to build on that, right? We have to understand the basis. Okay. Now, you'll also see things like seasonal affective disorder. Who feels sad in the fall or the winter? Okay, you're not alone. Okay, the seasons can do that. Also, cyclothymic disorder and postpartum blues, depression, and psychosis. Don't focus so much on this one. We cover that in 2030. But it is important to know there are subsets of it. Now, in general, major depressive disorder is twice as common in women. Okay. And if you have a first-degree relative with depression, you are much more likely to become depressed. Okay, it all has to do with those neurotransmitters and things like that in our brain. Okay, so that endogenous feeling. We don't really have a control over that. Okay, you see a lot in single or divorced people as well. Think of the lack of support system. Okay. Now, this isn't necessarily associated with issues in your brain, but it's associated with life factors, right? So if you don't have support, we call that exogenous depression. Okay, so from outside of our body. Sometimes we see it in a single episode. Other times it can be very recurrent. Okay, and we do classify it mild to severe. Okay, everyone here, you're in nursing school. It's not everybody's favorite thing in the world, right? And you may think to yourself, I'm depressed, okay? Maybe you're having a true single episode of depression, okay? But this, most of the time, is going to be lifelong. You're going to see more so the lifelong, okay? Depression is very dangerous if it's not treated. Okay? If anyone has ever felt those feelings before, you want to tell people that you're feeling that way? No. Okay, there's a definite stigma attached to it. So as a nurse, it's very important for you to have that one-on-one time with your patient to really figure out what's going on, because I promise you what they're telling you, it's 10 times worse in their head. Okay, just think about what you would tell someone if you were going through something. A lot less than probably what's actually happening. Okay. We do use something called the DSM-5 for diagnosing depression. Okay. And this is actually very important. You need to look at page 289 in your book, because we cannot diagnose someone with depression just because they tell us they're feeling depressed. Okay, they have to meet these criteria. So they have to have 5 or more of the following symptoms. I'm not going to list all of them out to you. Okay, but they are abnormal feelings and symptoms, right? But they have to be present within a 2-week period. Okay, so you can't just be feeling down for one day and get diagnosed with depression. Okay, it has to be some sort of pervasiveness. So even if it's a single episode, it needs to be how long? 2 weeks. Okay. And you have to have a change from your baseline. Okay. So it has to be a very big alteration on how they were previously functioning. Okay. And typically we're going to say there should never have been a manic episode or a hypomanic episode to be diagnosed with just major depression. Does that make sense for everybody? Okay. With the depression rating scale, this is listed in your book on box 17.1. And I can actually try to pull up this link here. There is a scale for cultural considerations. Let's see if it'll work or not. Okay. So here's the rating scale. Okay, so it classifies it based on an interview you have with your patient. Okay, those of you who have been to behavioral health, you've probably seen your nurses do this. Okay, we talk about mood. If you're feeling guilty, thoughts of suicide, that's a big one, and we're going to talk about that more. Anxiety, do they sleep at night? Again, that's huge for patients with depression and bipolar disorder. Okay. Are they getting through their daily activities at home? Are they taking care of themselves? Are they taking care of their families? Okay. Are they agitated? All of these things are very important. We have to look at the whole picture. Okay. But that scale has been shown to be reliable among different cultures, because remember, some cultures, we don't show those feelings of depression as much as others. So very much so, you may see other cultures that keep it all in because that's not something they show. Okay. It would be considered very taboo to do something like that. Okay. A lot of times these somatic ailments do accompany depression. Okay. You have a whole somatic micro lecture after your exam tomorrow. So I'm not going to dive too much into that, but it's those physical symptoms that can arise from having depression. But again, the manifestation does vary among cultures. And some of those cultures do not verbalize their emotions. Okay. So as a nurse, what do we want to do? Do you think we focus on our ABCs as much? No. What are we focusing on? Safety. Safety is our #1 priority. Okay. So if you ever see a question on a test or anything of that nature, safety is your #1. Okay. On that depression scale, there was a question, thoughts of suicides, thoughts of self-harm. If someone says yes to that, what do you think you need to do as the nurse? What's your #1 priority? You stay with them, right? You talk to them more, but you also do these suicide precautions. Okay, so if someone tells you this in your med-surg room, okay, if your patient tells you, you know, Kristen, I'm going to take this call light and I'm going to hang myself with it. Your #1 priority is to make sure that they're safe. You do not leave that patient to say, okay, you told me that, I'll be right back. Okay, because what they're going to do that. Okay, so make sure you stay with them, remove those things. Okay, if it's pulling that call light out of the room, taking it out, throw it into the hallway, that's what you need to do. Okay, I've had patients, you know, jump behind the nurse's station on behavioral health, try to grab things, telephone cords, right? Like the first thing we get rid of that stuff. Okay, throw it behind a locked door. Okay, so those are the things I need you to think about when you're looking at these kind of test questions and things like that. We kind of have to retrain our brain a little bit. Okay. Again, promote that therapeutic relationship, because again, they're not going to be so forthcoming with you if they think they're being judged or you're not hearing what they're saying to you. Okay. Again, if they are in a depressive state, they may not be taking care of their ADLs. They may have not showered for 2 weeks. Okay. So we need to develop that therapeutic relationship so we can say, hey, Susie, you really need a shower. Okay, I'm not saying that because I'm trying to be mean to you, right? You really need to take care of yourself. Okay. Also, if they're admitted, we're going to be managing their medications, or if they're outpatient, we're going to be managing those medications. And we need to provide teaching, because these medications are, you know, they can cause some serious side effects, and we're going to talk about that. So the first one we want to talk about with depression is your antidepressants. Makes sense to everybody, right? In pharm, you probably talked about those neurotransmitters in your brain. Norepinephrine and serotonin are your big ones. Okay. You need those neurotransmitters to feel happy. Okay. If they are decreased in a depression state, you are not going to be able to feel those happy feelings. Okay. That's that endogenous feeling of depression. Okay. Our antidepressant meds help establish a blockade so that we cannot take up all of that norepi and serotonin and throw it away. We need to be able to have it stay within the synapse and use it. Okay, does that make sense to everybody? So it's allowing those neurotransmitters to stay within the synapse a little longer. Okay. The big risk with that, though, is that those neurotransmitters can become in abundance. Okay, and we don't want that either. So we have to have a nice fine balance there. Okay. The big thing we want to have happen, this one right here, allowing the neurotransmitter to be more available. Okay. SSRIs and SNRIs are the two big categories that you'll see. So SSRIs are your selective serotonin reuptake inhibitors, so if it's a serotonin problem. And your SNRIs are both serotonin and norepi. How do you think a doctor figures out what to give a patient?
Trial and error.
Sometimes trial and error, and a lot of times doctors have a preference. Okay, so a lot of doctors like Lexapro, okay, or something like that. It just kind of depends on the doctor, okay? Because do we have a lab test we can give someone to say, hey, this is exactly the neurotransmitter that you're missing? No, and that's what's so difficult. So we do this all with symptom management and our one-on-one talks with the patient. Are things getting better? Are things getting worse? Another problem is this takes a little while to kick in. Okay, it's not immediate. Your SSRIs are your most common. Okay, the thing I want you to remember is this takes time, 7 to 10 days. That's when you're going to see the concentration, interest in life improving. Okay. Do you think in inpatient behavioral health, we keep every patient for 10 days? No. So are they going to be feeling better when they leave us? No, we can't fix those endogenous problems when they leave us. That's why we do dual therapy. We also do therapy with them and coping skills and all those things because we can't fix this quickly. SSRIs are pretty effective for most of your patients. Okay, the problem with these is, and patients don't like this, they're sedating, okay, maybe causing some anticholinergic effects. Who remembers what those are? It affects what neurotransmitter? Do you remember? Acetylcholine, okay. And do you remember what the symptoms are for anticholinergics? Think dryness, okay? Dry mouth, dry eyes, which is coming up on the next page, don't worry. But think dryness, also constipation. It will cause sexual dysfunction, but it's not so much the anticholinergic effect causing that, it's just the SSRI itself. Because of that sedating effect and those neurotransmitters being affected as well. Okay. But think about can't pee, can't see, can't spit, and I'm not gonna say the last one, but constipation, okay? That's what people always say to remember anticholinergics, right? Okay, but I'm not gonna cuss in here. But it is more safe to use an SSRI for the older adult population. Okay. But remember, a lot of times your older adults have issues with those things anyway, right? So we need to educate them, drink a lot of water, okay? Eat some candy if your mouth is dry, all of those things. Okay. They do have more low side effects than most other meds. And they are more likely to stick with it. Okay. Now, here's where everybody's gonna freak out. I know it's a lot. I do need you to know these meds. Like I said, however you learn them, that's up to you. Okay. Your book has a good layout for them as well. Okay. Pay attention to what is different color here. Do you see a trend? Okay, so with all of these, you're going to probably see some sexual dysfunction. Okay, some patients will quit their SSRI just because of that. Okay, educate them on those things. Dry mouth and throat, again, because of those anticholinergic effects. Okay. Which also makes sense, some of these other symptoms, constipation. Okay. Things like that. One way I learned these meds is I thought to myself, my teens, my leans, except for amitriptyline. Amitriptyline's a different kind, we'll talk about it. And your prams. So prams, leans, and teens, except for amitriptyline. Okay. So make sure, however you're doing it, if you're making a concept map, if you're saying SSRIs, make sure you're memorizing which ones I'm talking about, okay? Now, there are potentially life-threatening side effects from these. Okay, uncommon, but it can happen. Things you're gonna see if we're heading into a life-threatening side effect. Agitation, more so than your baseline, right? Because these patients can be agitated. Sweating, fever, they're gonna be very tacky. And when I say fever, I'm not talking about 101. I'm talking about 106, okay? Things that can fry your brain, okay? So that's why it's so potentially life-threatening, okay? Serotonin syndrome is a big one, but we'll get to that as well. Most of the time though, if we're heading into a life-threatening situation, it's because we're combining meds on accident, okay? So maybe you have a patient who went somewhere for depression and now they're at a new facility, but they don't tell their doctor they were on a certain type of med. And then we start them on an SSRI. Okay. And that would be, so they started somewhere else and they took an MAOI. Okay. But we didn't know that. So we prescribed an SSRI. Okay. That's potentially life-threatening. Okay. Do you think all patients with depression have good historic memories? Are they good historians? Most of the time, no. Okay. So you're going to see when you go to behavioral health, it's very important for a patient to sign a release of information for a family member or a therapist that they see or something like that. So we have a good background on what they've had done in the past. Because again, most of the time it's a recurrent state of depression. So they've probably been treated for depression somewhere else. Now, these MAOIs, we're going to talk about them in the next couple of slides, but as you can imagine, SSRIs are preferred, so you don't see MAOIs in practice as much. Okay, there's just a huge risk. But we're going to talk more about MAOIs. Tricyclic antidepressants, also you don't see these as much anymore. They are the oldest form of antidepressant. So those with insurance issues, okay, every older med costs less than the newer ones, right? So you might see that with someone with, you know, self-pay or maybe not the best insurance. Again, they also have a lag time, 10 to 14 days. Okay. But these can actually take 6 weeks to take full effect. If they have liver issues or a previous MI, they cannot take this. And just like your SSRIs, they can't be given with your MAOIs. Okay. So what are you picking up from me about these MAOIs? We need to have a few more interventions with this, right? Because we have to be very careful with our MAOIs. That's the big gist I want you to take from this. If they have too much of these tricyclics, they can become confused, agitated, have hallucinations. Okay. They can even go into a heart block. Okay. So we don't love tricyclic antidepressants most of the time. But for some people, they work very well. Okay. Most of the time, it's not going to be in the geriatric population. Why? They might have had a previous MI. Okay, or they may have alterations in their liver function. So we don't want to give them something that's going to make those things worse. Does that make sense to everybody? So if I ask you, what type of antidepressant do you not want to give to someone who's older? Your tricyclics. Here are some of your tricyclics. Okay. Now, these, I want you to pay close attention. These cause orthostatic hypotension. That's pretty characteristic of your tricyclics. Okay. Again, dry mouth and throat. Anticholinergic effects. Okay. Those of you who have been on behavioral health, or maybe a day or two of behavioral health, have you seen patients constantly drinking? Like, I finished my cup, I'm going to ask for another one. It's not because they're bored. Okay. They're actually feeling very thirsty because of that dry mouth and throat. Okay. Or some of your behavioral health nurses might think they're trying to flush the meds out of their system. That's another thing.
That's what I was told.
Yeah, they may be trying to flush them, but that's a whole nother story. So just remember, what are your anticholinergic effects? What kind of things are you going to see? With this one, what might help you? Think about your peens, your pins, or your means. I don't know if that helps you or not. Okay, so look at the ending of your words. So different than your SSRIs, right? Let's see how well we put it into practice. Okay. So 80-year-old patient, history of depression and BPH. Started on SSRI for mood stabilization. 2 weeks later, your patient presents with worsening urinary retention, confusion, and dry mouth. Considering the age and medical history, which of the following statements would be most accurate? Let me see that. Does anyone want the lights completely off? I don't want you to fall asleep. Can you see it okay? Okay, I'll leave it how it is. So where are we leaning here? C, okay? Because of those anticholinergic effects, right? Especially in your elderly. So that's how you're gonna apply those type of questions with your meds, okay? Now, what you might see though on your exam is instead of saying it's an SSRI, I'm gonna give you a name. That's why it's very important to know your names. Okay, because I don't want you to get to your NCLEX and they give you a med and you don't know what it is. Okay, and then you don't pass your NCLEX because your mental health was, your weakest subject. We don't want that. Okay. Atypical antidepressants, I'm gonna tell you right now, the doctors love these. Okay, you're gonna see these a lot on behavioral health. Okay, because they have multiple mechanisms of action. Okay. They still affect our neurotransmitters. Okay. And they affect multiple. Okay. So same with serotonin, norepi, but add in this dopamine. Okay. Do SSRIs or SNRIs, do they affect dopamine? No, thank you. But your atypicals do. Okay. Typically, we're gonna start them on an SSRI. And if that doesn't work, you're gonna see these atypicals. Okay, but more and more commonly, we see docs just starting them on atypicals. Why? A little less side effects sometimes, but they work a lot quicker too. And the effects seem to last a little longer. So that's one of the big reasons. Okay. So with their side effects, okay, so we have Effexor. Has anyone heard of Effexor? It's pretty common. Cymbalta, that's a big one right now. Wellbutrin, okay, that's huge right now. And Remeron. Remeron's actually used a lot of times for sleep. I've heard of that for sleep or seen that with your patients on med-surg. Okay, so pretty common meds. Wellbutrin is really good for patients who are trying to stop smoking. So it also helps a little bit with that addiction piece. Again, I need you to know that Remeron is an atypical antidepressant, but a lot of times we can use it for sleep. So do you think you take this one in the morning? No, you would take it at night. Okay. Questions on this one? Now, getting into the fun stuff, your MAOIs. Again, we don't use these very frequently because of those side effects. Okay, they interact not only with your SSRIs, they interact with herbal treatments, they interact with over-the-counter drugs, all kinds of things. The foods that you eat. Okay. The most serious side effect of just your MAOIs is your hypertensive crisis. So what do you think you're going to see in a hypertensive crisis?
Look over 180, diastolic over 100.
Mm-hmm. Was extremely high blood pressures, right? Sweating, feeling that impending doom, feeling really, really terrible. Okay, and sometimes this can happen pretty quickly. Now, this is even more common if you eat foods containing tyramine. How many of you guys think that you eat foods with tyramine in it? You probably do. Aged cheeses. Okay, so if someone's on an MAOI, you tell them you can never eat aged cheese. Okay, if you like blue cheese, this is out the window. Okay, you will give yourself hypertensive crisis. Okay, pepperoni. Sorry, you can't ever have pepperoni pizza again. Okay, Sausage, salami, any of those cured meats out the window. Draft beer, guys. Okay, so another reason these are not as common, because how many of your patients do you think are gonna be compliant with that? Okay, your pizza night, not only can't you have pepperoni, but now you can't have your beer with it. Okay. Yikes. There are other things too, like your overripe fruits, okay? You have a banana that's been sitting on your counter for a little while. Oops, you just gave yourself hypertensive crisis because it was a little overripe. Okay, that's why this can be dangerous. Okay, so if your patient is prescribed an MAOI, just make sure you're educating them on safety components of it. Because patients don't realize that. They're like, oh, my doctor told me I can't eat aged cheese. I'm just gonna eat it once. Right? A little won't kill me. Well, it could put you in hypertensive crisis. Okay, don't want that. It is listed in your book. I don't have the page number listed, but if you look in the glossary, you can find MAOIs, tyramine, and it's in there for you. If you want to know specifically the foods. But if I'm telling you, you know, your patient's eating some type of food and they're on an MAOI, you can probably assume there's gonna be an interaction there, right? If they overdose on these meds, it is potentially lethal. Okay. I had an adolescent patient one time, took the entire bottle of their grandparents' MAOI. Okay. Very dangerous. They were actually in the ICU before they came to me for a little while. Okay. Lag time with these still in effect, 2 to 4 weeks. Okay. If we are going to transition into an SSRI, you need to have a washout period is what they call it. Okay. And it's 5 to 6 weeks. We cannot, you know, shorten that at all. Interactions and overdose can lead to hyperpyrexia. What do you think hyperpyrexia is? Extreme fever. Again, this is that 106.7. Okay. Can actually cause cerebral herniation. Okay. And hemorrhage and death.
So like, what kind of?
It's a lot of doctor preference. They're not ever gonna get rid of them, right? They're always gonna have them as an option, because let's say you're allergic to an SSRI and you're allergic to some type of atypical, and you are at a big safety risk to yourself or someone else. We may have to use them, but I see them used very infrequently. But it's not something we're going to just say we're never gonna use. Okay. Serotonin syndrome. Okay. So this is what's going to result when you either don't allow enough of a washout period, okay, or you take too much of an SSRI, okay, so overdosing on your SSRIs, or you're just very sensitive to them. We actually had a patient go into serotonin syndrome on behavioral health not that long ago, and we weren't necessarily doing anything wrong, okay, it just happened. Okay, but what you're gonna see, excessive sweating, agitation. Okay, those are the big ones. Extreme tachycardia. They're gonna become hypertensive. Okay. And they're gonna have a lot of tremor. Their reflexes are going to be straight. They're also at a very high risk for seizures. So a list of your MAOIs. You have, how to pronounce this one well, isocarbazid, phenazine, I'm not sure if I'm pronouncing them right, translycamine, and then, I don't even know, NSAM, you guys. Just know that these can cause those symptoms, right? So be careful with mixing any tyramine foods with these, Tyramine containing foods, allowing that washout period, right? All of these things I have highlighted for you up here. But let me ask you, are any of these names similar to any of the names that we've had before? No. So that's kind of how you're going to be able to identify, oh, that might be one of our MAOIs. Again, here's some foods with tyramine. Okay, I got a little bit ahead of myself, but they're kind of all listed here for you, so most of the big ones. Okay. So a lot of things you guys might eat every day, right? Or at New Year's, they can't enjoy sauerkraut. Okay, no luck for you the coming year. I'm gonna try and keep you guys awake. Okay, fun one, ECT. So used to be, I think we'll cover ECT in the tape. Used to be ECT was only done at Marion Hospital, Ohio Health around here, pretty close to us. Ohio Health Mansfield has ECT now. Okay, so those of you going to Ohio Health for behavioral health, you may have a patient going to ECT and you might get to see that. Okay, a lot of people think that this is barbaric. Okay. Has anyone seen this on the movies or anything like that?
They're trying to ban it. Like, there's a lot of people against it.
Yes, there is a lot of people against it. There's a lot of stigma with it. Okay. We use this in extreme cases, okay? So patients who are taking antidepressants, okay, and we're not having good management of that, okay? Their depression is out of control. Or if they're on a therapeutic dose of a medication, they cannot handle it. Okay? So if they're having extreme side effects, they can't handle the dry mouth, the dry throat, all of those things, we may try ECT therapy. This is where we put those electrodes on the scalp. Okay, it's going to send an electrical impulse to the brain, and they're going to have a seizure. Okay. A lot of times they're sedated, right? So they're not going to be conscious for this, right? They're going to be sedated. And then the reason that we do that too is we don't want them to have that tonic-clonic, right? We don't want them to have the shaking limbs. We don't want them to be a risk to themselves for safety. But we do invoke that seizure. And there are studies that say it helps with their depression symptoms. The shock can also help correct those chemical imbalances that cause depression at its root. Okay, so you may not have to have ECT your whole life long. Okay. Usually Ohio Health, I believe we're starting with about 5 sessions or so. Okay, so they'll stay inpatient admitted for their sessions. Okay. It's kind of doctor's preference how often.
You're in the hospital, do they do it in the actual unit or?
They go down to the operating room for this. Yep, because they actually have to have anesthesiology protect their airway while this is going on, right? Because they're sedated.
Is the controversy really over like the long-term loss of memory? Because some people say that.
So we're gonna talk about that actually.
Yeah.
And I have it highlighted for you. It's actually short-term memory loss, and it's
Okay.
very, very common. Okay, so they may not remember that morning of their ECT treatment. Okay. I did care for a patient in Marion as a student who had ECT done, and it's like they come out of it and they're very, very tired. They just have seizure, right? And they're very foggy for that day usually. So they're very like, I don't really know what's going on. Okay, so, and it's part of that like retroactive amnesia that they have going on. Okay. And some people think that that's not ethical.
I was gonna say, if it helps the problem, like what is so wrong about that?
It doesn't always help. That's the thing. It's not guaranteed you're going to feel better with this.
Is it like a temporary thing?
Maybe temporary, yeah. So maybe you come for ECT and it helps for a little while and you're doing better, and then you may have to come back and have it done again. So also it's expensive, right? You're going to the operating room to have this done. Okay, so it's way more expensive than your medications and things like that. So again, only in those extreme cases. But yes, for this series of 6 to 15 treatments, okay? So we start out with 5, see how they're doing typically, okay? And then they're gonna come back for more at some point. Preparation is gonna be similar to any outpatient surgery. Okay, so as the nurse, you're still prepping them for surgery, right? Having them take care of their ADLs, making sure they void before they go down there, because during a seizure, are you protecting your bladder? No, right? So doing things like that. NPO after midnight, again, because they will have an artificial airway placed of some kind. All this is going on, okay? IV needs to be in place. So on behavioral health, do you think we just always have IVs all the time? No, we can have them. They just need to have closer monitoring if they're locked. If they're having an infusion on behavioral health, they're gonna be a one-to-one patient, just like they are in med-surg. Okay. But if it's saline locked, typically we can kind of just round on them more frequently. And that sort of thing. But again, short-acting anesthetic and muscle relaxant, because we don't want them to have that full-blown tonic-clonic type seizure. Again, after the treatment, all of your patients are gonna be mildly confused, right? That post-ictal state, very common. Just remember, what's your biggest deterrent? Okay. Some studies will say it's as effective as meds. Others say it's only a short-term fix. Or they'll say it's not helpful at all. It just kind of, it's all across the board. And that's another reason people are just like, well, I don't want to do it. We actually had a patient on behavioral health. Some patients in behavioral health are not their own guardians. Okay, they're adults, but they have to have a guardian within the legal system, right? Like an attorney or someone like that, because they cannot make their own decisions. Okay? They have to go through the court process to have that done. But I had a patient who had ECT and she was not her own guardian, so we had to force her to go. Okay, so it wasn't her choice. So that was pretty tough. Bless you. There is a video we'll watch when we come back, but I do want to give you your break. So go ahead and take 10. Okay. And we'll watch the video when we come back.
It's always sad.
After you.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or who are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
Typically indicated for treatment-resistant psychiatric conditions, most commonly mood disorders or depression, but there are multiple types of depression, so it can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
For the patient to sleep, the stimulus is delivered, the seizure is monitored, they'll have just one seizure.
An electrical current is given to the brain, low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. Thanks to the anesthetic, it's very hard to tell. In fact, only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens
So you
soon
can
after
imagine
and is
if they
monitored
didn't
for
have those
short.
sedatives and things for their muscles, then they would have more of a full-blown tonic-clonic seizure, right? Because we can still see some of that muscular activity, but it's not as
Patients who have
pronounced.
undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown, for the WVU Health Report, I'm Dr. Wallace Sullivan.
Any questions on ECT? Again, controversial, but it is good to have that option if you have someone who we cannot treat otherwise, right? So medication issues or things like that, okay? Make sure I started. Okay. Let's go back. So psychotherapy. This is what you're going to see on the inpatient units, okay? So it's a combination, medications and that therapeutic, relationship, therapies, going to groups, okay? Things like that, very, very important, okay? We need a combination of both. Interpersonal therapy, that's what we use to focus on difficulties in relationships. So those patients who are recently divorced, okay? Or maybe they recently lost a loved one, a grandparent, a child, whatever it may be, okay? So dealing with grief, role changes, things like that. Okay. Behavior therapy, so that's to help positively reinforce those interactions your patients have with you or their environment, okay? And we want to not encourage any of those negatives that they have, right? So any type of positive behaviors we want to encourage, but negative we do not. What do you think would be like a negative behavior? Your patient says, I smoke marijuana to cope. Is that a positive? Or I do meth to cope. Okay, well, that one, I've heard that one too. Well, that makes me better. Okay, that's negative, right? We try to give them some positive. What are positive things you think you could encourage?
Breathing exercises.
Breathing exercises, okay? Any distraction technique, music, movies, whatever it may be. Those are positive things. Reading is a big one. Okay. Puzzles, anything that gets your mind off of it. Okay, those are positive. Okay, but we don't want the negatives. I self-harm and that makes me feel better. Okay, there's another negative. I cut and that makes me feel better. That's a negative. Cognitive therapy, how does the patient think about themselves? How do they think about others? Things like that. Other somatic therapies you might see, we talk about this a lot more in your somatic micro lecture. Okay, so I'm not going to go super in depth in this because we talk about it a lot. The transcranial magnetic stimulation, okay. Magnetic seizure therapy, deep brain stimulation, and vagal nerve. Okay, so these are for those somatic illnesses, those physical symptoms that you see. So that's going to be on your micro lecture, but I wanted to include it here. Okay, so your plan of care, what assessment data do you need? Okay, a lot of this you guys already know, okay, but I want to talk about why it's important in this setting. Okay, the big ones, star, highlight, whatever you need to do. Suicidal ideation, anyone who's depressed or bipolar, you need to ask them this question. Are you having any thoughts of self-harm or harming others? I don't flat out say, are you suicidal? That sounds a little more judgmental, right? Rather than, are you having any thoughts of self-harm or harming others? Because sometimes it's not that they want to harm themselves, they want to harm you. Okay, because they're so agitated and frustrated with the world. Okay. Think about those young kids, those adolescents that are going into schools, okay? They may be depressed and unhappy with their lives and they're taking it out on other people. So we have to ask both. Does that make sense to everybody? And I know it's a tough topic. Let's talk about it. Okay. You may also see slow mental processes. Has anyone helped with an admission at the hospital and there's a question that says, has anyone seen you moving slowly or talking so slowly no one can understand you? Has anyone seen that question? There is a question like that on your assessment at the hospital. So sometimes you may notice those slow mental processes because there are those alterations in those neurotransmitters in the brain. Not always, but sometimes. Also disordered thoughts, hopelessness and worthlessness. No, big thing for you guys to know. Guilt, are they guilty about something, losing a loved one, okay? We've had patients crash their car, lost their kids. There's a lot of guilt associated with that. Anhedonia, you may not know this term, but it's an inability to experience pleasure or happiness with anything. Okay. So I used to like to bake, but now I don't receive any happiness from doing that anymore. It doesn't make me happy. Another one I want you to remember is sleep disturbances. Okay, we talked about that quite a bit. Ruminating, okay, has anyone done any ruminating before? Okay, in nursing school, that was me after every exam, I'd ruminate about it. Okay, you just have to move on from it. Right, but these patients who are depressed, they can't do that. They'll ruminate on something that happened 12 years ago. Okay. Delusions, hallucinations, or other psychotic symptoms. Usually not as common in your depression, but they can have a psychotic break. Okay. More so common in bipolar or your schizophrenia, things like that. Diminished interest in sexual activity. All of these things are very important, but you guys know this is a change from normal, right? This is a symptom of depression. Okay. The big one I want you to understand for planning care. The patient needs to be free from self-inflicted harm throughout hospitalization. This includes cutting, self-mutilation. Okay, we've had patients try to take erasers and burn themselves. Okay, anything you can think of. When you guys go to behavioral health, they can't have pens. They have metal in them. They can't have staples with their paperwork, okay, because they can use those to harm themselves. They don't get regular sized pencils. They get golf pencils. Because if they try to harm themselves or stab themselves with it, it's not gonna go as deep to hit any vital organs. Things you don't think about, right? Okay, or if they try to harm you, it's not gonna harm you, hopefully, that badly. So these are some things you may see in your plan of care, but the big one I want you to pay attention to is your self-harm. Nursing actions, again, providing a safe environment. This is like repetitive, right? But that's okay. Observing their potential for suicide. Okay, so are they making statements that are a little funny? Okay. Has anyone heard of people selling some of their prized possessions? Okay, things that are not normal. Okay, I waited all year for these Taylor Swift tickets, but I want you to have them. And they can go. It's like, why aren't you going? I won't need them. Okay, we need to go further, right? Things like that. Using a moderate tone. Don't be overly cheerful. I know everyone thinks when you go to behavioral health, you have to be that person that's like, are you having such a great day now? You think that's what they want? No, they want you to recognize like, hey, I know, I'm your nurse today. This is what they told me about you. Why don't you tell me a little bit about yourself? What makes you happy? What do you like to do? Don't be overly cheerful and assume that they're doing better because it's going to take them a lot of time, okay, and work to get there. Using silence is okay. It gives them a chance to think about what you're saying and also not to kind of just give you what you want to hear. Okay. A lot of patients will just say what you think they want to hear and they're not actually okay. But we need to be active listening. So it's okay to use silence. Okay, avoid asking too many questions, that's a gimme. Okay, when you go to behavioral health, there's typically a list of questions we want you to ask, and they're all safety-based. Okay. Those of you who had clinical with me, what are the big ones? Shout them out. What do we ask?
Having any feelings of harming yourself or others?
Mm-hmm.
Are you seeing, feeling, touching, anything that I can't see? Are you seeing anything, smelling, yeah, all those things? Anxiety, depression,
Appetite, yep, anxiety, depression, sleep. Yes, all of those things, all the things that we've talked about, very, very important. Okay, but we don't want to probe them. If they're not giving us information, we can't say, tell me right now. We can't do that to them. We give them space if they need it. Okay. One thing they need to understand though is if you're not opening up and you're not responding to these treatments, you're gonna stay longer because we don't know that you're gonna be safe to go home. Right? I always tell my patients, you're not forced to go to groups, right? You're not forced to go to therapies. But how do we know you're gonna be safe going outside of here if you don't participate? Right? So you allow them to have their free will, but at the same time, you have to have them understand what's going to happen with that. Okay. So bipolar, we're going to transition over. your extreme mood swings, and I'm sorry, this kind of made it small. But they're gonna go from those manic states, so those up, can't sleep for days on end, and then they're gonna go into about a depression at some point. Each of these could last for weeks to months. This is second to major depression in terms of worldwide disability. So if major depression is what you most commonly see, bipolar is typically your second most common. The lifetime risk though is only about 2% for adults and children. Bipolar disorder. But it does occur equally in men and women. And it's actually more common in highly educated people. Which is kind of interesting. That first manic episode will typically start in teens, 20s, or 30s. I can't tell you on the adolescent unit how many times we have a patient come in with their first manic episode. Because you stick an adolescent without their phone, without their PlayStations, their computers, on a mental health unit for 5 days and see what happens, right? They go a little stir crazy. Okay, and they're manic, so to top it off, right? There is also diagnostic criteria for this, okay, in your DSM. So to be diagnosed with bipolar, you have to meet the criteria. And this is for a manic episode. Okay. So it's a period of persistently elevated or irritable, expansive mood. And it should last at least 1 week and present most of the day, nearly every day. Okay, so they may not be manic 100% of the time during the day. Okay, but it needs to be at least a majority. Now, some of these patients, I promise you, they'll go 36 hours without sleeping, and then they'll crash for a little while, and they'll get back up and do it some more. Because eventually your body just says, enough. Okay. During that period of time, you have to have some of these symptoms, okay? The big one is this inflated self-esteem or grandiosity, okay? I can fly off of this building. I can fly. And I'm gonna show you that to do that. Do you think they're more at risk for harming themselves? Yes, because they have that sense that they're invincible. Okay. Grandiosity, I had a patient one time that told me, when you leave work today, I'm gonna have a Porsche sitting there for you. I said, I'm not gonna say never. Right? But I knew there wasn't going to be one. Okay? But when they're in that state, they think that that's true, you know? So it's that grandiosity. Okay? Decreased need for sleep. Okay? They might feel rested after just 3 hours of being knocked down. Okay? So the body just says, hey, you're gonna have to sleep for a little bit. They lay their head down for 3 hours and they're back up for another 24. Distractibility, that's another big one, okay? But any of these things, and again, you know this isn't normal, okay? So if I give you an exam question, you're like, that's not normal. What does it fit to, right? Do our depressive patients have this grandiosity and they're running around and they're trying to jump on buildings? No, that's more so your bipolar manic patients, okay? Foolish business investments, I can't tell you how many times you see that, okay? And then that leads into probably a depressive state because now we're okay. I love my husband dearly. I tell him this all the time, but I'm like, I think you're a little manic, honey. You know, I'm very gentle about it, but I'm like, I think you need to be evaluated. Because I'm not kidding. He'll buy like 5 pairs of shoes. And I'm like, you gotta stop. Like, there's gotta be a stopping point, right? You have to prioritize some of the things you want. But he'll do this, like the fad diets and the fasting, and like, he's like, and I can do this, and I'm gonna go work out, and he does it for a week, and then he's done. And I'm like, I think something might not be right. And I tell him this too. If you ever meet him, or if you ever see him meet us out and about, he knows I talk about this. But then the big thing is too, the manic episode needs to be followed by a hypomanic. So still a little manic, but not as extreme, or a major depressive episode. Okay. This is a great picture. I wish I would have had this in nursing school, guys. It shows the different types because we have the 3 different types of bipolar, and this is where it gets confusing, but look at this picture, okay? Bipolar mixed, you're gonna have periods of mania, normal mood, and depression. See how this fluctuates? Okay, so think about the bottom bar, your depression, normal, and then manic. Does that make sense to everybody? Mixed, you're going through all of the motions, okay? All of the feelings. Bipolar type 1, you're mostly elevated. Okay, you're mostly manic. But you have to have that depressive episode. Okay, does that make sense? Is what we're following? And then lastly, your bipolar 2, mostly depressive. So they're kind of inverse of each other. Okay, so mostly those depressive. Usually they don't get to that full manic state, but some hypomania. Okay. Something like that. So I told you, I think my husband's a little manic. Okay, that also means that he can be down here sometimes, because I think he's got a little bit of bipolar, right? So immediately after he's buying all these shoes, he's having some of this guilt, okay, foolish investments, and then he's like, I just can't remember this, right? It's like, I need to go somewhere, right? But in all seriousness, it's the up and down, okay? Does that make sense to everyone? But you have to have both at some point. Okay. Interventions, again, safety is your top priority. If they're having grandiose thoughts and they're wanting to show you that they can fly and do things that the human body cannot do, you need to reinforce that you can't be doing those things. Okay. I see this a lot in the adolescent patient population. Standing on top of the tables and they're wanting to show you their dance moves and then they're like, I can jump. No, don't do that. Right, because they're very manic, they're very excited, okay? On behavioral health, we have weighted chairs. I think they're about 25 pounds. And we would have this patient who'd be like, I'm gonna put all the chairs on the table. And he'd just start putting all the chairs on the table. I'm like, well, now how are we gonna get them down? Right, because most of your behavioral health nurses are these tiny girls. And I'm like, well, now we're gonna have to call security to just get the chairs down. But it's true, they get very excited and they have that elevated thought process, okay? Again, meeting their needs, okay? Because they're probably not eating, they're probably not drinking like they should because they're so excited about everything else that's going on. Okay. Therapeutic communication. Do you think it's hard to have conversations with these patients? Okay. Do you think they want to sit down with you for a 20-minute long one-on-one? No. Okay. So I would pace the halls with my patient while I'm trying to get the assessment questions in. Right? Things like that. Reinforce, okay, and promote those positive, appropriate behaviors, okay? We don't want to be punitive if the behaviors aren't what we want them to be, right? But we need to say, you have to keep yourself safe, okay? It's okay that you're feeling excited and doing all these things, but you have to keep yourself safe while you're doing it, okay? During this time, we're gonna manage meds, okay? Sometimes they need some PRN meds to take their mood down a little bit or to help them sleep, okay? So we have a med that's called Atarax, you'll see, or hydroxyzine. And that one we use PRN to help kind of take the edge off of it a little bit if they need to rest or if they're anxious, okay? It's like a cousin to Benadryl. So you guys know when you take Benadryl, it makes you pretty sleepy, right? Similar to what that med does. So if you're unable to do the things you need to do, sometimes you need those extra meds to help. And then we're gonna provide teaching to the patient and family. Again, these patients are not very receptive to teaching at the time. So it's very important that we educate whoever they're at home with, right? Wives, husbands, children if they're older, right? Parents if they're younger, things like that. Treatment, okay? They are going to be on a lifetime regimen of meds, okay? Think about depression, right? We can use other coping skills and things like that, use meds for a while. Do you think those patients can eventually come off of meds if they're depressed? Sometimes, okay? Depends on how severe their chemical imbalance in their brain is, right? These patients, because it is such a perpetual cycle, should be on medication. big one you'll see sometimes is lithium. Okay, helps with that manic state. Do you think patients like to go from manic to normal? No, okay. A lot of these patients like their manic state, it's their favorite time. They feel really good, they feel really elevated, and we take that away. Bring you back down to where we are. We also use therapy with that, right? Help them cope with the things that are going on. Typically, this is going to be most effective during those depressive or normal parts of the cycle. So we have to bring their mood down to normal before we can start with that aspect too. There have been times we've had patients in group and they're so distracting, okay, to the group process, we have to ask them to head out. Right, if you can't stay on topic with us, you're distracting from everyone else's experience. We need to give it a little bit of time, you can come back later, right? Because we don't want to distract from what everyone else is going through or doing. Okay. And there is very little insight. What do I mean by insight, do you think? What would tell you that someone has insight? Understanding. So if I said, Tammy, you seem a little elevated today, what would show insight if she were to respond? Oh, yeah, I just right? I'm kind of bouncing off the walls a little bit. So self-awareness, right? Think about that. So also if I would have said, yeah, Tammy, you seem a little elevated today. No, I don't. I'm fine. You're the one who's down. Okay. Things like that. Do you see the difference there? It's that self-awareness piece. Like, yeah, I know I'm not quite right. Okay. A lot of times there's very little insight during that. Okay. Lithium, let's talk more about it. The response rate in acute mania is actually pretty good, 70 to 80%. Okay. Because it helps mute that cycle of the up and down. It especially brings down those manic episodes, brings them back down to our level. Now, what's funny about this is the mechanism of action is a little bit unknown, okay, but it does help to hasten the destruction of those catecholamines, okay, especially your dopamine and norepi. So think about your neurotransmitters here. Does take a little bit of time. Now, you can start to see the effects of lithium in about 5 days. Okay. Our typical treatment time on an inpatient behavioral health unit is 5 to 7 days. Okay. So typically we're going to start to see this work. Now, lithium does cross the blood-brain barrier. Okay. So if a pregnant woman is taking lithium, it does cross. Not only to the baby through the placenta, but also in breast milk. Okay. And it can cause first trimester developmental abnormalities. Now, when you get to 2030, we'll talk about all the things that are happening to your baby in the first trimester. It's a very important time for development. So these patients, if you have a woman of childbearing age on lithium, what do you think you need to tell her? Use birth control, okay? We need to be very careful with that because we don't want to cause these developmental abnormalities. And she's gonna probably have to stop taking it and switch to something else for quite a while because if she plans to breastfeed, it's also gonna pass through breast milk. Okay. Lithium, you need routine blood draws to check for toxicity. I can't stress that enough. Very dangerous to not. Okay. We're gonna do this weekly when we start treatment and then about every 3 months. Now, you might say, that's well and good, but what are my therapeutic levels? So for acute treatment, when we have a patient on the behavioral health unit inpatient stay, 1 to 1.5 for your lithium. Okay. So on your mental health paperwork, when it talks about, say levels or something like that, drug levels, lithium's one of the ones you need to know what their drug level is. Okay. Now, if they're chronic, they can be about 0.6 to 1.2. That's considered still effective. Okay. Help manage those highs and lows. make sense to everybody so far? All the time. Yep, because remember, it's lifelong, right? We need to be on something for mood stabilization. Yes, very good. So we had a patient one time recently on the behavioral health unit, was in this nice range, 1 to 1.5. Got discharged and came back about 2 weeks later, maybe a month. And we took their lithium level, and they were at 0.2. And they're back in behavioral health. What do you think happened?
Stop taking it.
Stop taking it, right? She's like, no, I've been taking my meds religiously. We're like, really? Blood level says that you haven't been taking it. So what's been happening? She's like, well, yeah, I didn't quit it. I'm like, well, yeah, we knew. But we can't outright say you haven't been taking it. It's like, it's more like, tell me what happened, right? Did you miss a refill? Kind of probe that way, right? Not to say you just stopped taking your meds. So got her started back up on lithium, started checking her pretty frequently, and we got her back up to the level we needed. Make sense to everybody? Okay. Now, if we're on the higher range, if we get above that 1.5, okay, we're gonna start to see some mild toxicity symptoms with lithium, nausea, vomiting, lethargy, tremors, fatigue. You're gonna see that between 1.5 to 2.5. So there's a nice little bit of give there with your toxicity, right? When you say if normal is 1 to 1.5.
To see a tremor with that
Without being above.
yeah.
Depends on the person. Yeah, typically you don't really see a tremor, but you could. But again, you're probably gonna have multiple of these symptoms if you're getting into the toxic range, especially if you're on the higher end, right? That's when you're like, yeah, you're gonna see some tremors and some vomiting and things like that. With moderate, think mental status changes. Okay, confusion, agitation, delirium. This one, instead of tremors, you're gonna see that hypertonia, okay? Think about that. So your muscle rigidities or your hyperreflexes, all those kind of things. That's 2.5 to 3.5. And your severe coma, seizures, hyperthermia, hypotension. Okay, this is dangerous. This is life-threatening. And that's with greater than 3.5. Okay. So if someone's in a depressive state, okay, and they take their whole bottle of lithium, okay, that could be a life-threatening situation. So this could be a high-risk drug. You need to make sure you're educating them. Make sure you're taking this as it's prescribed, right? You don't just take 2 because you're feeling down one day or you're feeling up one day. It's always take it as it's prescribed. A lot of patients think with these, behavioral meds, they're like, oh, I'll just take it when I'm feeling bad. Okay, that's not the way we do it, right? We have to be consistent. Anticonvulsants can also be used as mood stabilizers. Who's surprised by that? Kind of was when I started in nursing school. But we can use anticonvulsants to help stabilize that mood. Okay, for patients who do not respond to lithium or can't take it. So think about maybe you're pregnant patients, but anticonvulsants are also a risk, right, for pregnancy. So we'll talk more about that. So if they have a lot of side effects from lithium, we may be able to switch over to some anticonvulsants. Okay, or if they have certain medical conditions like renal disease, lithium is hard on the kidneys. Again, similar to your lithium, the mechanism of action is largely unknown, but it may help to raise the brain's threshold for dealing with that external stimulation. Sometimes you'll see these used with antipsychotic meds. We talk about these a lot next week, okay? Abilify is a big one. Has anyone heard of Abilify? Okay. I actually really like Abilify. My patients on Abilify have really good mood control typically, and it works pretty quick. I really do like Abilify. And then Rexulti, That one's actually a little newer. You don't really see that as much on our behavioral health units around here because it's expensive. And then Vraylar. Okay. So those can be used as well. Oh, yes. They'll be on a lot of dual therapy for sure, especially if they are very, very sick. Yes, absolutely. So some of the common ones, you might see carbamazepine, Depakote. Okay. Depakote, we check out valproic acid levels, so please write that down next to it. Okay, because that one we do check the level. Gabapentin. Who's seen patients with gabapentin? Did you know it can help stabilize their mood? I mean, it definitely makes them happier, right? Because it helps with the nerve pain, but it can also be used as a mood stabilizer.
Can you repeat the acid for the Depakote?
Valproic acid, and it's in your book. Yes. And then we have Lamictal, okay, and Topamax. Now, what do you see is in common with these meds? Hypotension, what else? Blurred vision, dizziness, right? So what do you think these patients need to be? Educated on sitting, standing, all those things, right? A fall risk, okay? Think about your fall risk assessment, med surge, anywhere you go. What do we put in there for meds? Do you have a checkbox that says anticonvulsants? Yes, right? So when you're doing your fall risk scale, that's actually something that can make you on a higher fall risk. And that's why. Now, the plan of care, what are we going to assess? A lot of things we've talked about. Are they oriented to self and time? Some of your patients will tell you that I am, I'm Donald Trump. It's like, okay, I know where we're at. Okay, things like that. Are they concentrating? Can they sit and put a puzzle together for more than 2 minutes? Sometimes you'll see patients, they'll come sit, color a little bit, and they're automatically back up. Okay, and they'll come back and do it a little bit. It reminds me of my kids, because I don't make them sit at the dinner table and eat. They'll go come get a bite, and then they'll run off, and they'll come get a bite. Right, it's stuff like that. Loose associations. Okay, poorly associated ideas. They'll be like, oh, I went to Walmart, and then the cat was touching the bird, and then they'll be like, oh, and then I went to the pool. It's just things that are like all over the place, and you can't really follow it. Okay. Push of speech, they're gonna talk very pressured. Okay, sometimes it's very hard just to understand what they're saying. Hallucinations. Are you seeing anything that I might not be able to see? Are you hearing anything that I might not be able to hear? Do you feel things I might not be able to feel because they might feel bugs crawling on them? Okay. Sometimes olfactory, it's a little less common, but they might say they smell flowers or something terrible. It just kind of varies from person. And then delusions. Okay. Delusions of persecution. Everyone's out to get me. Delusions of person. I'm Donald Trump. Right? No, we're not. Another one of those. Okay. Expected outcomes. Okay. We want them to remain oriented. That's a big one. If they're having hallucinations or delusions, we want to help decrease those in about 24 to 48 hours. Think about all those problems we talked about. This is how are we going to fix those things? What are our goals of treatment? Okay. The big thing is we want to sustain their concentration so that they can live life, right? So that they can take care of themselves when they go home. These are just some examples for you. I don't need you to memorize all of these, right? I just need you to be able to understand what are you going to do as the nurse. Okay. One-on-one time is very, very important, but you need to make sure their behaviors are appropriate, okay, and safe. Decreasing stimuli helps a lot, okay, but it also makes it harder to deal with these things. Okay, like I said, at 4 o'clock in the morning, you have one manic patient on the unit, going down the hallways. who are they talking to? Themselves or me for 5 hours? And I'm like, I gotta step away, right? I'm like, I cannot talk to you any longer about this subject, right? I have a lot of patience, but that's very thin. In the morning, but it is very difficult to manage, you know, for long periods of time, okay? Behavioral health, Mansfield, they used to be on 8-hour shifts, okay? Now with 12-hour shifts, it gets pretty difficult to manage this for 12 hours, okay? It's very emotionally and physically taxing sometimes. Questions on those? Do I need you to memorize all of the plan of care ideas, all of the nursing actions? No. But I do need you to recognize what things would you do to help someone dealing with these things. Okay. Let's talk about cognitive disorders. A lot of this should hopefully be review. Let's see how you do with it. So when I talk about neurocognitive disorders, I'm talking a lot about delirium. Okay. And it can be classified major neurocognitive or mild. Now, dementia is still used as your diagnostic criteria, but is dementia the same as delirium? No, because dementia is what?
Breakdown of your brain tissue, so.
Exactly, so does dementia get better over time? No, but can delirium get better?
Yes.
Yes, so that's why they're vastly different, okay? Chapter 24 focuses on delirium, dementia, and the similarities between the two. Okay. I have it up in the corner for you, so page 450. So delirium is actually termed by the disturbance of consciousness by a change in cognition, okay? And a lot of times this happens on med-surg. Think about your sundowners patients and things like that. Patients who don't have dementia, but they start to get a little funny, right? They start to hallucinate a little bit. Their times get all messed up while they're in the hospital, right? Or they were just intubated for a long period of time and you bring them out and they're like, what's going on, okay? My grandpa, he didn't have dementia, but he was like, your birds are flying around your head, Jordan. And I was like, oh no, is he gonna get better? I was like 14 at the time, right? I was like, he's not right, okay, but it can get better, okay? Characterized by a short period, okay? Dementia is gonna be progressive over time. Delirium happens pretty rapidly. And it can fluctuate throughout the course of the day. These patients are gonna have trouble paying attention. They're gonna be distracted. Again, hallucinations. Jordan, I saw birds flying above your head. Okay, a lot of times this happens because of that disturbance in the sleeping wake cycle. Okay, very common in the hospital. Sometimes just a very big emotional stressor can cause these things too. But there's something else going on to cause this. That's the big thing I want you to understand here at the bottom. There's something else going on. Intoxication or drug withdrawal. How many of you have cared for a patient on a CWA? Do they have delirium? Okay. Can they turn into something called DTs or delirium tremors? Life-threatening, right? So make sure you're understanding of those things. So if we fix the cause, okay, so if we fix the withdrawal cause, do those symptoms get better or worse? Better. Drugs can also cause delirium, okay? But it all makes sense if you think about it. If someone's under anesthesia, are they cognitively right? No. There's some kind of alteration to their cognitive status. With all of these meds, right? Things like that. Okay. Antihistamines, Benadryl. Has anyone ever had Benadryl fog? Take it to go to sleep and then the next day you feel like, all right. Okay. Think about stuff like that. Okay. So any of these drugs can cause that. But what I want you to be able to do is to recognize it. Okay, and how do you keep your patients safe? Okay. Now, we need to remove whatever's causing that. That's the main priority. So your CWA patient, we need to treat them, okay? Maybe they need a little bit of Ativan. That's one of your first line treatments. If they're agitated or in psychosis, we need to treat them with antipsychotics. Has anyone ever given Haldol? I've given it about 200 times. Okay, because we also give it for patients who are agitated in the hospital. Okay. But I've given it on med-surg quite a few times as well. Okay. Does it sometimes make patients a little bit worse? Yes. Okay. Because it also falls into some of these type of drugs, okay? With alcohol withdrawal, again, we treat that with our benzos such as Ativan. Okay. We don't typically want to give any benzos to our older adults because it can worsen it. Right? Has anyone ever seen orders come through for your agitated patient and it's Ativan and you've seen your nurse go, oh no. It can sometimes make things worse. Okay. Than phenobarb for what, withdrawal patients? It depends on what your orders are, but Ativan for your CWA, yes, phenobarb more for your other types of withdrawals. Always make sure they're still eating, drinking appropriately. Okay. So that's not the thing that they're concerned in a delirium state. They may need IV fluids or restraints if anyone's safety is happening. Assessment data. So what are we looking for? We're gonna have poor judgment, cognitive impairment. That's your big one. Star that one, highlight it. Impaired memory. Limited insight. We talked about insight, right? They're gonna feel like their personal control is gone. And we need to assess for hallucinations. Okay, we'll talk a lot more next week about hallucinations. Big thing, we want them to be free of injury, injuring self and others. Okay. On med-surg, I almost had a lady take a chunk out of my arm and she was in delirium. One of my first Haldol experiences. I was like, somebody needs to help me. I was very nervous. Now I give it all the time, right? You grow. Okay. We want them to be trusting of the caregiver or someone they're familiar with, hopefully within 24 hours. Okay. So it's always good with the delirium state to have familiar people around, right? Similar with your dementia. And we want to eventually get them back to optimal level of functioning, right? Their baseline. Can we get a dementia patient to their baseline before they had dementia? No, that's the big difference. Okay. Again, very repetitive, but safety, help with their confusion, orient them. Okay. Keep the lines open during the day and dark at night, right? So it helps establish their cycle. Reduce sensory overload. If there's a pump beeping constantly right next to your patient with delirium's room, what do you need to do with that pump? Get it under control, right? That is a sensory nightmare for these patients. Okay. Making sure they have proper sleep and proper nutrition is key. Now, we talk a lot more. We have a whole substance abuse, CWA, all kinds of stuff. This is just an introduction, but you do, thank you. So this is your CWA, right? Clinical Institute Withdrawal Assessment, alcohol scale. Has anyone ever scored a CWA with a nurse or done alcohol? Okay, so there's a lot that goes into it. We always check blood pressure, heart rate, okay, because these patients, their blood pressure is typically going to go way up. And that can score them higher on this scale. Tactical disturbances, they might feel itching, pins and needles, hallucinations. It varies from person to person and how severe. Auditory disturbances, visual disturbances. Okay. Now, if they have hallucinations, it's automatically going to score them pretty high. 8 to 10 at Ohio Health. If you score an 8 to 10 in this scale, you're getting meds. And under 8, so 7 to 0 is supportive therapy. Okay, so making sure they're comfortable, making sure they're fed and hydrated, all of those things. But But if they're scoring 8 or higher, they're getting some form of meds. Now, there's a scale, we'll talk about that more. But I just need you to know, we need to address this if we scored 8 or higher. Now, I do want to touch on dementia. You should have learned about dementia in previous courses, but I do want to talk about it just a little bit to talk about the differences. Remember, dementia is progressive cognitive impairment. It's not going to get any better. Okay. Now, remember from past courses, aphasia is the deterioration of your language. Okay, they can't form their words, whatever it may be. Apraxia is the issues with motor. Agnosia, that's the inability to recognize or name objects. Okay, so forks, they don't know what that is. Okay, things like that. And they're gonna have that disturbance in executive functioning, so they can't think abstractly, they can't plan, initiate, sequence, do anything that requires that executive function. So do you think these people are gonna be able to maintain jobs? Especially as that gets progressively worse. Okay, go ahead and take a break. Okay, I do want to be mindful of your guys' time, so I'll get started. Again, this is stuff that should have been covered already, but I do want to make sure you understand, because if I'm giving you questions on delirium, I need you to understand that it's different from any of your dementias, right? And things like that. So the paper, this purple handout paper, make sure you get each of those handouts before you leave. But types of dementia, this previous slide, I'm not going to cover super in depth just because it's on this paper for you, okay? Now, the thing I find fascinating is this prion disease. Has anyone ever heard of a prion? Okay, pretty hot topic right now. So it's a protein that can trigger your own proteins to fold abnormally in your brain. And it's very rare, but Creutzfeldt-Jakob disease, okay, so you get this from eating infected meats, things like that, from cows that are infected with prions, okay? And the reason it's a hot topic right now is because we no longer test for prions in our meat anymore. I'm surprised at that. Now, you can go down a whole rabbit hole of this and get yourself all psyched out and really nervous about these things, right? But it's so serious that some morticians and things like that won't perform autopsies on patients with CJ or Creutzfeldt-Jakob disease because it's so very, what's that word? It's transmittable. So we don't want that, right? So, and it is a definite indication that you're going to pass away from this disease. There's no way to fix it. We used to test our meat for that, and we don't anymore. So you can go down that rabbit hole sometime if you'd like to. Parkinson's. Everyone's probably seen a patient with Parkinson's at one time or another, right? Also progressive neurologic condition. Okay. Think about those tremors that you see. Okay. Postural instability, things like that. Then Huntington's disease. Has anyone heard of Huntington's disease? Very sad. Okay. Inherited disease. Typically, these people with that diagnosis are not going to have kids. It's very common to pass that on. Okay. Now, again, not going to go over that too super in depth, but the treatment. Okay. Treating that underlying cause. Okay. Vascular dementia. We might try to help with that with diet, exercise, control of hypertension. Okay. These are your dementia meds. Okay. What do dementia meds aim to do? Slow the progression. Are they a cure for dementia? No. Thank you very much. That's good. So remember, symptomatic treatment. We may be able to help with those symptoms, okay? But we're not going to be able to cure dementia, okay? We may also have these patients on some form of antidepressant, antipsychotic, or a mood stabilizer, okay? Because we need to treat those symptoms. Okay. Nursing interventions similar to all the ones we've been talking about, providing a safe environment. Making sure that they're not going to trip over things, making sure everything's clear. All those things that you look at when you first go into a patient's room. Okay. They're going to probably need help with feeding themselves, dressing themselves, all of those things. Okay. Providing emotional support, not only to the patient, but the family. A lot of times the patient doesn't know that they're that sick, right? They're just going about their life day to day. But the family are the ones who are gonna be very impacted. Okay. Self-awareness. There is a lot of an inability to teach with dementia, right? So our teaching, we have to be very careful. Who are we gonna primarily aim our teaching to? The family, the caregiver, the spouse, whoever it may be. Okay. They may feel frustrated or hopeless. Okay, that's the patient or the caregiver. If the patient is starting to notice the decline in themselves, especially early on in dementia, right, they're going to be frustrated. Okay, but as the disease gets worse, they're not going to understand that they're that severely declined, right? So there is not, like, a lot of patient families, when they're first diagnosed, if they don't know anything about, anything medical, right? They're gonna be like, well, they're gonna get better. Right, we have to be the ones that say, this is not gonna get better, we need to prepare for what's to come. So making sure there's someone that can care for that patient, if not, maybe we need to look into some assisted living arrangements or something like that. Okay, now, this is what I want you to really pay attention to. Delirium versus dementia, I need you to understand the differences between the two. Okay, so if I give you patient symptoms, how they're acting, what the onset was, all of these things. I need you to be able to distinguish what is going on with them. Does that make sense to everybody? So I know everybody's nervous. They're like, oh, I don't know how this is like a test, all this stuff. I need you to be able to apply this stuff, just same as Mrs. P, right? We're very similar. Okay. I need you to be able to read through some of these symptoms and say, oh, I know exactly what this condition means. Let's talk about suicide now. This is a very touchy subject. And I know that. So I do understand that this is a sensitive subject. Okay, but it is something very important that we need to discuss. Okay. Again, this is recorded, I'll post it later, so if you don't want to stay, you don't have to, that's completely up to you. But suicide is defined as the intentional act of killing oneself, okay? We have suicide in itself, and then we have suicide attempts, right? People who attempt but do not complete suicide. Emphasis on this. So suicidal thoughts are more common in mood disorders. That's why we talk about mood disorders first. Do you see where if you feel a loss of control over your life or your symptoms, you may think that this is your best option? Okay. So we have to kind of get into the mindset of someone else, right? Because it's very different. Each year, more than 45,000 suicides are reported in the US. Does that surprise anyone? A lot. Okay. Attempt rates are 8 to 10 times higher than the completed suicides. So this is when we find this, okay? In behavioral health, the students know this. We had a patient attempted hanging themselves and the family had to intervene. Patients who don't stop the act themselves. So if a patient takes pills and they bring themselves in, I took, half a bottle of Tylenol, we worry about them trying to complete suicide while they're admitted rather than we worry more about someone who did not come in for help, right? Because they were caught in the act. Someone who brings themselves in, that's a little bit better of a sign, right? That they're ready for treatment. Okay. Men complete 72% more of suicides. Does anyone know why?
Financial stress.
Maybe as a cause.
You mean like they don't talk about it?
They're more.
Yes, so maybe they're dealing with more financial burdens, but they do take more extreme measures. Okay, so things you can't back out of. Okay, shooting themselves in the head, you can't stop that once you've started it, right? Hanging, very hard to stop once you started. They do more lethal measures typically. Okay. Women, you might see them taking pills more commonly. Poisoning's a big one with women. Okay, things like that. Then a lot of times I see like jumping into traffic too, or off bridges and things like that. Again, things you can't necessarily stop once you've started to do those things. Okay, that's why it's more lethal. That's why they complete more suicides typically than women. Okay, but here's the caveat to that. Women are 4 times more likely to attempt. So think about that. So men are typically more likely to commit, women have more attempts. And again, it's because of the ways they're going about it. Okay. So who's at risk? Again, men, young women. Think about those life stressors, okay? Separated or divorced, and greater than 65 years. So a lot of times it's really, really sad, but we have, especially these male geriatric patients come in and they're like, well, everyone I know is gone. You know, if they're extremely older, I had a patient who's like, well, my kids are all dead, my wife's dead, it's just me, and my kids never had kids, I don't have any grandchildren, I'm living this life alone. And then his cat died. I'm like, oh, goodness gracious. You know, because it's like he had nothing, no one. Right? So think about those life circumstances, okay? Suicide is the second leading cause of death among people aged 15 to 24. Okay? So again, think about those young people. It is so sad that suicide is the second leading cause of death for those ages. I love working the adolescent unit in Mansfield Behavioral Health, but it's very sad. Very sad. Okay. Because what's going on in schools right now, it is not nice. Kids are not nice to each other. And when they come to behavioral health on the adolescent side, they are not nice to each other. They say things to each other that I would have never said to anyone growing up. Okay. For example, there was a patient interaction I had one day. I was working and the one patient was like, they were kind of getting into it back and forth. You know how adolescents do. And the one adolescent said something like, well, at least I didn't try to kill myself. I'm like, okay, we're not going to do that today. Okay, because we can't talk to each other and continue to do these things that we do outside of here. Something has to change, and it can start with you. Okay, because they're very impressionable. So it's very important if you know, when you go to be mental health, these adolescents, that's the future. We need to start treating each other much better. Now, the rate is increasing a lot among 45 to 65 years old. Okay, but think about some of the things that are going on in life. Okay. Cost of living, all of those things that they're trying to deal with. Okay, medical factors, think about this, chronic illnesses, this makes sense to everybody, right? If you are chronically ill and in pain every day of your life. Okay. Environmental factors, if you're isolated, if you're homeless. Okay, we have a lot of homeless patients on behavioral health. We had a recent loss like the patient I talked about. Okay. Just losing a job, that's huge. Okay. Traumatic life events. And again, that family history, we always ask about it. So how do we understand how this starts? It starts with the suicidal ideation. So this is why we asked, do you have any thoughts, right, of killing yourself or anyone else? Again, it's homicidal as well. Then we need to know, is it active? Okay, because you can have fleeting suicidal thoughts, okay? But there's a difference between the thought popping into your head and then you're like, thinking about ways you're gonna do it. It's very different. Okay, so if a patient has an intent, okay, you'll hear the word intent, okay, or a plan, that is much more dangerous. Okay, so if you ask a patient, are you having thoughts of self-harm or suicide? And they say yes, then your next question is, do you have a plan to act on those thoughts? And most of the time, they're gonna say no. Whether that's the truth or not is a whole nother topic. But if they say yes, we need to remove any of those things that they're talking about, right? So if they're on behavioral health and they're saying, I'm gonna hang myself with my towel when I go to take a shower, well, you're not getting a towel. We're gonna wait to shower, okay? We have to make sure that they're safe, okay? Passive suicidal ideation, that's again, you think you have those passive thoughts. Wishing that you go to bed and not wake up. Okay. Thought of, I wish I wasn't here anymore. But they don't necessarily have a plan to cause their own death. They're just like, if it happens, it happens. That's what attempted suicide, again, there's either with attempt, okay, there's either gonna be completed, which is a suicidal act, right? They had a suicide, or they may have a failed attempt or incomplete. That makes sense now. The myths. People that talk about suicide never commit it. This is not true. Someone can talk to you about it and still commit suicide later on. Okay. Another myth, suicidal people only want to hurt themselves. We talked about this earlier. That's not true. Think about the people who crash into other people. Okay. Maybe their intent was to hurt someone else on their way out. That's possible. Think about your people who use suicide by cop and things like that. They may want to harm someone else and they get taken out. Okay. All of these are real things that happen. Okay. Another one, there's no way to help someone with suicidal thoughts. Yes, you can. It starts with us, it starts with nurses, it starts with us asking those questions. Another myth, you shouldn't say the word suicide to a suicidal person. That's not true. Okay. And a lot of times, sometimes you'll have a patient come up to you and they'll say, I'm having a lot of suicidal thoughts today. Okay, I have that happen all the time at behavioral health. It's like, okay, let's talk about it. Do you have a plan? No, okay, let's talk about it more. What's causing your thoughts? What triggered that? It does not give them the idea to commit suicide if you mention it. It's not something you're going to cause. You never want to ignore a suicidal threat. And this is not true either. Once a suicide risk, always. That's not true. You can be suicidal at one point in your life and never have that happen again. Or it can be a recurrence. Suicide assessment data. So we need to know, what are your history of your attempts? What kind of methods were you thinking of using or used? Okay. If you have a history of attempts, it does increase your risk for a subsequent attempt, especially if it's been 2 years or less. Any immediate relatives who have completed suicide? If you're on current antidepressant treatment, you're more at risk. Does that surprise anybody? Again, think about that lag time of your meds, right? And even once your meds start working, it could give you more energy to act on any suicidal thoughts you might be having. Also, what's one of the side effects of your SSRIs? Suicidal thoughts, worsening mood, right? It doesn't always help. It's one of those side effects. Watching for those signals we talked about. Direct, I've been thinking about doing this, taking all my meds. Or indirect, I just can't take it anymore. Or some of those things that they're doing, selling prized possessions, giving things away, making arrangements for their family members, things like that. So, how do we assess for this? We use this Columbia rating for Ohio Health Mansfield. That's why I kept it, so you see this when you're on the floor. Okay. So we're gonna recognize the verbal or behavioral cues and ask our questions. Okay, and you can look at this when you go home too. Okay. So the first question is, have you wished you were dead or wished you could go to sleep and not wake up? That's kind of like your intro baseline question, right? Because that's just the thought, I wish I wasn't here. And then it moves on to, have you actually had any thoughts of killing yourself? So then we kind of dive deeper into it. Okay. But whenever we do this, we need to make sure we're also assessing any support that they have. Do they have a plan, all of those things? Okay. Now, client statements, how are we going to respond? So we need to be direct, right? Everything I've said has been direct. Right? There's no sugarcoating it. You ask your questions, you have to do that. Okay. Again, are you having any thoughts of harming yourself or others? If yes, you follow up. And there's also a page 317 in your book, Box 17, which has some good examples as well. Any questions so far? Now, nursing interventions, okay? Following your institutional protocol for risk assessment, okay? Has anyone been in healthcare when they still use the SAD assessment tool? Heard of the SAD assessment tool? They changed it to this Columbia scale that I had before because they found that the SAD assessment scale was a little bit more so based on things like gender and things like that, rather than asking those direct questions about your past, okay? So make sure you're following whatever protocol you see used, okay, because every facility is different. Then you want to record any behaviors that you see, okay? Contracting for safety. This is kind of being phased out in most places. Has anyone heard, do you contract to stay safe while you're here? Right, so do you promise to keep yourself safe while you're on this floor? Okay, we're doing away with that because patients aren't truthful, right? You can't take that for 100% certainty that they're not gonna harm themselves, okay? But I will ask a patient, you know, I'll ask my questions, and if they're having thoughts of self-harm, and if they say no, I'll say, will you tell me when those thoughts arise? And if they say yes, I'll put that in my charting. Patient states they will come to staff should these thoughts arise. But that's not them promising me that they're going to be safe. Okay, there's a difference. Encouraging the discussion of feelings with your patient, letting them to be open, okay? Having a non-judgmental approach. And then we need to have support from family and friends. Again, your social worker, your best friend in these situations. Okay, so they're gonna help with that follow-up piece. They're gonna help get in contact with these family members. Always remove whatever, whatever the attempt was. If they came in for a hanging attempt, we need to make sure we're removing things from the house. If they had a gun in their hands, we need to remove all weapons from the home. Okay. And then try to have them avoid any major life decisions during their crisis time. Because that just adds unnecessary stress.
To remove the like guns and weapons and stuff, would that be something where you'd have to call the police and get them involved, or how would you go about doing that?
We can't force that, right? So we are giving them the tools and the ability to be successful when they're discharged, hopefully, right? We're not gonna discharge someone who's actively suicidal. Does that make sense to everybody? So we are talking to the family, hey, can you, get a safe, lock these things up, things like that. If it's something that's like a shared possession or something like that. Adolescents, we say, parents, you need to get it out of the house, right? But we can't force them to take it. Does that make sense to everybody? But we're gonna strongly encourage it. Because remember, that first 2 years after an attempt is your most likely time they're gonna repeat that. And providing those community resources. Every patient should have a follow-up appointment when they leave the behavioral health inpatient unit. Okay. So your patients who are on med-surg 1-to-1, they should be evaluated by the psych doctor, and they should have follow-up appointments as well when they leave the hospital. Okay. So our goal is suicide prevention, keeping the patient safe environment. We don't want any ligature risks, no ties. Okay, they are not allowed to have hoodies with strings in them, pants with strings in them, none of that. Okay. They can't even have a notebook with a ribbon in it. Like that, anything you could think of for someone to harm themselves, they will. Okay, we used to let our patients take their deodorant back to their room to put it on, and then someone busted their lid on their deodorant and started cutting themselves with it. Now you can't have deodorant in your rooms. Things you wouldn't think of, right? So we have to be very careful. Treating the underlying disorder is gonna be your best bet to prevent any future attempts, right? So we need to stabilize that. Coping skills, so important, we talked about this. Reading, distraction, deep breathing, all of those things, okay? Remember, what are your positive ways to cope? What are your negative ways to cope? Okay? Encourage therapeutic relationships and then promote those cultural practices that are positive. Okay, if they're spiritual, encourage that. Okay, but you can't necessarily encourage that to someone who's not spiritual, right? So we have to be careful. So we want to promote positive practices. Self-awareness, this is what I want you to think about when you go home. If you're working in behavioral health, everyone will get a chance to go, right? And everyone will see this in MedSurg or wherever you decide to go. How's your empathy with this population? Do you feel empathy for these patients? Okay. Because I know sometimes you don't. Right? So assess yourself, right? What is your self-awareness? Does this stuff make you sad? Okay. Is it hard for you to cope with? Okay. Some people may unconsciously try to avoid patients because it makes them very sad. Okay. We have to be careful of that. Okay. Caring for patients that are manic can be exhausting. I talked about this. It is very taxing. Okay. Healthcare ethical views. Some people think suicide is immoral or these patients are unworthy of care. Are they unworthy of care? No. Because remember, a one-time suicidal risk does not mean you're a risk for suicide your whole life. Okay. And of course, be aware of your own thoughts and feelings. Okay, if you're struggling with something, you need to tell somebody. Okay, if you struggle with mental health, if you have family members with certain conditions and it's going to be difficult for you, you need to communicate that to one of your instructors. Okay, so just keep that in mind as you continue on with your mental health journey. So today was a lot of introduction. The big things I need you to focus on. Okay, I know you have an exam tomorrow, but don't let your mental health slip. Okay. Mental health is typically one of the more difficult tests just because it's a lot of information. It's usually a lot of new information. Some of those meds, okay, you learned them in pharm, but I need you to look at them again. Okay, understand that. If you need to see me, you can come see me. I have office hours, same as this piece, really. Like we're pretty much the same. And I wish you all the best of luck on your test tomorrow. Not to doctor it for you in 107. Thank you guys. If you didn't get your handouts, make sure you get them before you leave. Nice pictures and stuff like that on there.